Morning everyone. Welcome back to Mondays. It was Wednesday last week, bit weird, a bit disorientating. Welcome back, Steph. Good morning. Hope you're well. Busy week this week, Steph. Well, the end of the week anyway. It's an exciting one. We did the ligaments of the cervical spine on Wednesday last week. Just going to do a quick recap on those, and then we'll start to add on the muscles to the neck. So we'll have a look at the different kind of aspects of the neck, some of the deeper structures, and then back out into the more superficial ones. So hopefully there'll be a bit of a logical flow to everything. If that's okay. So here are the ligaments that we covered. Not going to go into great detail because this was obviously done all last week. I can imagine, Steph, yeah, especially after all that time. Morning, Martin. Morning, good to see you there as well, mate. One of our stalwarts on a Monday. So we've got the, in fact I've missed one out. This one here, the apical ligament we had a look at. And when we looked at the bony anatomy of the neck, we've got the dens or the odontoid peg of C2. And that has quite a few ligaments attached to it to make sure that it's stable, keeps it in place. One of them is this apical ligament, which is just there. Just grab my arrow. So it's this bit here. So there's the peg. You can see that the C1 has been cut, so the atlas has been cut so that you can see the peg. And then we've got some other ligaments in here as well. So we've got the alar ligaments, these ones, and then the transverse ligament as well. And we looked at all of those last week. So those three key ligaments that keep that peg in place and allow that rotation in the upper cervicals. Ligamentum nuchae, or the nuchal line, it's basically the nape of the neck, and it fills in the lordotic gap. Okay, so where there's a lordosis in the cervical spine, so probably hear that the if the microphone's good enough, that the recycling guys are collecting the recycling. They're not all our wine bottles, I promise. Morning, Becky. Good morning. Morning, Jane. Good to see you. I haven't seen you for a while. Good to see you back. The nuchal line is in the nape of the neck. And I was just out of curiosity, was doing a bit of research on the etymology of the word, and it basically comes from nape of Latin, so the nape of the neck. And then I was looking then at animal anatomy, and basically the ligamentum nuchae in animals is to maintain the head position, like in dogs and on horses, and obviously it's a lot bigger, so the muscles don't have to engage all the time on the posterior neck. They've got this whacking great big nuchal ligament, whereas ours is, because we stood upright, we don't need to lift our head against gravity. It's not as developed. So I thought that was quite interesting. Good morning, Mo. Good morning. Good to see you in as well. So that was the ligamentum nuchae, which is this bit here. And again, I'm flying through these because we covered them last week. Okay, so so Latin for neck, or the nape of the neck specifically. Supraspinous ligament, we've covered loads of times. Superior to the spinous processes, and it links into the nuchal ligament at the lordotic part of the cervicals. So you've got the supraspinous here, all the way up there, and then around about C7 it then changes into the nuchal ligament and then attaches onto the base of the skull. So you can see it's it does fill that lordotic gap, and muscles will attach into it, which we'll have a look at today. Interspinous, so in between the spinous processes, just there. So again, we've covered this quite a few times as we've worked our way up the spine. Anterior longitudinal, so a long ligament that goes on the front of the vertebral bodies, and that is, again, that's from the base of the skull all the way down to the sacrum. so it covers the whole spine, not just in the cervical region. And then that links into, just skip forward a couple. Yeah, so we've got the posterior longitudinal and the tectorial membrane. So the tectorial membrane is one of the inner coverings of the brain, and wraps on the inside of the skull, and then comes out through the foramen magnum, which is basically means big hole at the base of the skull, and that's where your spinal cord comes through. And at the front of the foramen magnum, you've got this tectorial membrane that envelops everything around the skull, but it merges into the posterior longitudinal ligament, which is just here. Okay, so anterior longitudinal is front long ligament, posterior longitudinal back long ligament, and again that goes the whole length of the spine. Is it very strong? Yes. Yeah, it's pretty strong. It's may get injured in like a car accident or something like that if you have quite a severe sort of flexion extension whiplash type injury, likely to get injured then. You might have a nuchal tear, but it's pretty tough stuff. And the thing about dogs is, if my dog's misbehaving and I need to control him, then that's where I grab him. and obviously that's where they mums pick up their pups and carry their or their kittens or whatever it is. Any of the animals where they're on all fours, they're going to have quite a well-developed nuchal ligament. So yeah, in the animal kingdom, very tough as well. Yeah, so that was the tectorial membrane, which merges into the posterior longitudinal. So that's part of the layers that are on the inside of the cranium. Okay, so one of the kind of dural layers that wrap around, connective tissue layers that wrap around the inside of the skull. So yeah, it's continuous with the posterior longitudinal ligament. Let me just get rid of that. And the dura mater, which is this bit here. Okay, so there's the skull, there's the dura. So it's part of the meninges. That's the arachnoid layer, that's the pia layer. We have covered these before, but a long time ago. And we looked at them when we looked at the spinal cord. So it might be worth revisiting those if you've not really heard of these before. But these layers, the kind of triple layers that surround the brain and then come down the spinal cord, okay, and wrap around it. But they merge into the ligament structures as well. Okay, so it's all a continuous network. Then we have the yellow ligament, the ligamentum flavum. This attaches between the lamina, okay, so above and below on the lamina. So again, this one helps with resisting hyperflexion. So if the spinal column is being moved forward quite rapidly, then you can get an injury to the ligamentum flavum. And I was saying last week, this often commented on MRI reports, a hypertrophied ligamentum flavum, for example. And the reason why it's commented on is because if it does grow, if it is hypertrophied because of stress, and then it responds to that stress by laying down more tissue, then it will close up this gap, which is where your spinal cord is. So obviously it can impact the spinal cord, and especially if you have a disc bulge at the same level, then it just kind of squeezes that space. So that's why it's often mentioned on MRI reports. Then these are the ones we looked at the beginning with the apical ligaments. We have the alar or wing ligaments. These attach onto the peg as well, onto the odontoid peg. So we had a look at that last week. And then the cruciform or cross ligament, which is another one that attaches onto the peg and to the skull to keep the odontoid peg in place. Okay, so that was all our ligaments from last week. Quick whistle stop tour. Now we're going to have a look at the muscles. So If you've been doing body work before, you probably will have heard of the suboccipital muscles. The occiput area is the back of the skull. Okay, so if you have a feel on the back of your skull, there's usually quite a prominent bony lump right in the middle at the back. And I need to look at what this means actually. So if anybody does have a bit of time, have a look. But it's called the inion. Okay, so INION. I don't know how, I just remember random stuff. But that join at the back of the occiput, where there's a protuberance there, and that's called the inion. And if you can feel your inion, and then just come underneath it into the soft tissue, that's your suboccipital region. Okay, so the inion is a good marker, bony landmark to be able to identify those structures. So Steph, is the LF something that is common in lower back pain? What's LF? What have I said that might be LF? I've no idea what that means, Steph. Sorry. It's probably something really obvious that it's just got over my head. Yeah, let me know what LF is and then I'll let you know. So your suboccipitals, there are several of them. There's quite a few. Okay, and you'll get some on some courses I've been on, people say, oh yeah, you can feel the rectus capitis minor, you can feel the rectus capitis major, and whatever. When you see the cadaveric specimens in a second, I doubt that very much. Okay, so if we have a look at where this attaches, so your inion is going to be around here, so that's your bony protuberance on the base of the skull. Just tucked underneath that, we've got rectus capitis minor. So it's on the posterior arch of the atlas, so that this area here of the atlas, so that's the one that rotates around the peg. And it's on the inferior nuchal line of the occipital bone, so underneath where the nuchal ligament attaches. Okay, and what it will do is it will extend the head, because of the orientation of the fibers, and there are several of these. So let's just show you all of them. So there's rectus capitis major. This comes down a little bit lower. Yeah, so it's actually on C2, this one, so the spinous process of C2, so the axis area, again onto the inferior nuchal line. So the nuchal line will be up around here, and it will be just underneath that. Okay, so it's right deep in the kind of base of your skull, really. Okay, so that suboccipital obviously just means under the occiput. Okay, so we've got rectus capitis minor, rectus capitis major, and then we've got some oblique muscles as well. So this one attaches from C2 onto the transverse process of C1. So that's the atlas. That's the axis. You can see the peg there. So this will rotate. So the spinous process of axis onto the transverse process of the atlas, and then it rotates, which makes sense. Okay, because if you have a look at it, the oblique fibers, if they contract together, you're going to get rotation of that C1, and the skull sits on C1. Okay, so it will turn with it. It's not going to be one of the prime movers of rotation, because it's a very, very small muscle, but it will assist with the movement of your upper cervicals. So when we were doing, we were talking about this a couple of weeks ago, I think, where there's a test you can do where you can try to isolate those upper cervicals to see whether it's the upper cervicals that are restricting rotation. So if you rotate the head normally, see how far you can go, and if it's like restricted, you go, okay, let's see if it's the middle to lower cervicals that are restricting it, or whether it's more the uppers. So then you bend the head completely forward and then rotate and see what rotation they've got there. So if the rotation in the uppers is quite good, But then when they have their head up and then they're rotating side to side like normally, it's reduced, then it's more likely to be those middle and lower cervicals that are causing the problem. But if it's the other way around, where your head's forward and then that's restricted, then when you're doing your soft tissue work or your muscle energy techniques or whatever it is you're doing, then you can't isolate the muscles in here, but you will be more likely to be working on these ones, the suboccipital, especially this oblique capitis. Okay. Cool. And then we've got another one, and this one attaches onto the skull though. So we've got transverse process of C1, so on the atlas again, and then the posterior aspect of the occipital bone, so just underneath there. So we've got lateral flexion and extension of the head on this one because of the orientation of the fibers and where they are in relation to each other. So we're going to have a bit of extension with that capitis muscle. Cool. Right, let's have a look at this. I don't know why it's very funky. My image is sweeping in there. I don't know how I've done that, but yeah, I'll take that. Looks good. Okay, suboccipitals, here we go. Okay, just pause this here. So there's the base of your skull, just there. That will be the posterior arch. Okay, so that back section of the atlas. So we can see already, I mean, this has been amazingly dissected. So we can see each individual muscle, and then you'll think, oh yeah, it must be really easy to palpate each of those because you just put your finger straight on it. But on top of this, you have got maybe another at least 2 layers of muscle, plus subcutaneous fat, plus nuchal ligament, plus skin. Okay, so there is a lot of tissue before you get to these deep suboccipital muscles. Okay, so yeah, to be specific on which muscle you're on is impossible, I would suggest, in this region. You will have an idea roughly of where you are, but you can't just isolate and impact one of the muscles. Yeah, so it's going to be a group that you will affect. So we've got rectus capitis minor, rectus capitis major. So if you remember, the minor was posterior arch of the atlas, and then onto the inferior nuchal line, and then the rectus capitis major was the spinous process of C2, and then onto the inferior nuchal line. So one was started a little bit lower, one started a little bit higher. So let's have a look at those. So there's your rectus capitis minor, and there's the major. Let me just pause that there. So yeah, so these ones here, yeah, those are the minors, and these ones here, these are the majors. Okay, so they're in like a V shape coming up. Obviously, when we looked at it before, there was only one on the image, so this one here, but obviously it's paired. Yeah, so we've got muscles on either side. So that's the minor. This one just here, and then the major is this one here. Okay, so that one starts a little bit lower, so that's on your C2, and then comes up onto the base of the skull. And then we can see here, these are the oblique muscles. Okay, so we've got the inferior one and then the superior one. So the inferior goes one way, superior kind of comes back and comes the other way. So that one onto the transverse process, and then that one from the transverse process onto the base of the skull. So you got obliquus capitis superior. Let me just rewind that again. Let's have a look at that again. So rectus capitis minor, rectus capitis major. These are in such a small space. They look really massive on this image here, but they're in such a small space really. Yeah, so that's your major just there. And then when we come around to the side, there's the oblique. So the inferior oblique, that one there. And then superior oblique, that one there. Okay, so this one is the one that will help with rotation. and then the other one was extension and lateral flexion. Yeah, so you can see it just attaches on the base of the skull there. Cool. So those are your suboccipital muscles, which again, like I say, you may have heard of as just well, we could call it suboccipitals, but sometimes you don't get the breakdown of what each. It's like the quads. Yeah, we call it quads at the front when we first start learning anatomy. And then you go, oh yeah, there's a vastus medialis, vastus lateralis, vastus intermedius, rectus femoris, and you start learning the names of the muscles and the origin, insertion of, or the attachments of those. Similar with the suboccipitals, kind of group them together when we're first learning, and then well, hopefully now you know what they all are, and the whole group of them together. So next one, deep neck flexors. So we're going to have a look at the anterior neck. We've got the longus cervicis, or the longus coli. Okay, this is really popular in Pilates. From the Pilates instructors that I've known, they've all known about longus coli. In fact, when I was doing my anatomy dissection stuff, we had a Pilates instructor who was dissecting the neck to examine the longus coli. That's what their project was on. So we've got the anterior transverse processes of C3 to C6. Okay, so the anterior part of the side sticky out bits, and then the anterior bodies of C1 to C4. So it kind of twists around and comes onto the front of the vertebral bodies. Starting around onto the front of the bodies as well. And then the insertion is the anterior occiput, so on the front of the occipital ridge, and C5 down to T4. So you can't see it on this image, but we'll have a look on the videos. Okay. What it does is it's a flexor, which makes sense because of where it's attached, and but a weak flexor, because if you want to flex something strongly, you're going to need an attachment point that is away from the hinge. Okay, but these attachment points are all really close to each other. Okay, so that they're literally on top of each other. So they're not going to be able to generate much force in terms of flexion. There'll be other muscles that are prime movers in that role. They will have a role to play, but they won't be the main mover. Okay, so let's have a look at that. Here we go. So these are the deep neck flexors. Oh, and a bit of scalenes as well, thrown in for good measure. Here we go. So this is obviously a bit different to what you saw in the image because it only had the top part of the muscle, but this is the extent of it. Okay, so it is quite a long muscle, but do you see what I mean with its attachment points? They're really close. So if I wanted to flex the neck forcefully, I'd want a muscle that attaches here and then onto the manubrium there. So it's in front of the area that I want to flex. Yeah. So if it was attached up here and then onto there, that would be a pretty strong neck flexor. Yeah, because of the angle. But because the muscles are really close to the to where the joints are, you're not going to be able to generate much force. So it will still flex the neck, but just not forcefully. Okay, so anterior transverse processes C3 to C6, so that's at the top here. Anterior bodies of C1 to C4, so that's up here as well. And then the insertion anterior occiput, and then C5 down to T4. So you can see it goes all the way down to your thoracics. Yeah, so it's a really long, really long muscle that covers all of the front of the cervical spine. So this is your longus coli or longus cervicis. So it's got a few names and some muscles merging together as well. So base of the occiput here, transverse processes here. bodies of C1 to C4. So you can see the attachments on that little bit, and then all the way down to T4, so on the front of the thoracics. Okay, let me just pause that there. Cool. Okay, let me just go back. We'll do that one again. I'll add on the scalenes in a sec. So let's have a look up here. So there's the base of the skull. So there's the anterior occiput just up there. Transverse processes of the cervicals, body of the cervicals as well, and then all the way down, and then attaching really deep on the front of transverse, the thoracic spine down to T4. Cool. Okay, right, let's have a look at the next one. So around this area again, we've got the scalenes as well. So the scalenes, we're going to talk about these quite a bit when we get to the shoulder, because we're going to do a session on the brachial plexus, which is the nerves that come out of the neck. So we'll do an intro to that on this round while we're looking at the neck, but then we'll follow the pathway of those nerves, and the scalenes is a really key point for where they come through. As is the blood supply. So the blood supply comes through the scalenes as well. And that's really important clinically for something called thoracic outlet syndrome. So you can have a neuro cause of thoracic outlet syndrome, or you can have a vascular cause, or a bit of a combination of the two. So the nerves can become compressed, the blood supply can become compressed, and that they both give you slightly different symptoms, but quite often it's the scalenes that are causing the problem. So the scalenes, there are 3 of them. We've got the transverse processes of the 3rd to the 6th cervical vertebra, so 3rd to the 6th. That's going up a little bit higher on those. 1st and 2nd ribs. So that this particular image is only coming down to the 1st, but it does attach onto the 2nd as well. So what they do is they will move the neck, okay, so bilaterally, so if both working together, you'll get elevation and of the rib cage and flexion of the neck. Yeah, so these are an accessory breathing muscle. So when you have to like get forced inspiration and you're trying to maximize the amount of air in your lungs, the scalenes will kick in to lift those first couple of ribs to help maximize the space. Okay, and they'll both work together, both sides. Unilaterally, we'll get lateral flexion to the same side and rotation to the opposite side. So similar to the trapezius muscle, because of the orientation of the fibers. So let's have a look at that one. So we'll skip forward a bit on this video. Here we go. So here we're going to bring in the scalenes. There we are. So these are the scalenes coming in here. So we've got an anterior, a middle, and a posterior. And can you see there's a little gap here? So that little gap there between the anterior and the middle, that's where your blood supply comes through for your arm, and also the nerve supply for the upper extremity. Okay, so it's really important region for symptoms into the arm or the hand. So those are the scalenes there. So yeah, anterior at the front, then we've got a middle, and then we've got a posterior just there. So they're attaching onto the cervicals and then down onto the ribs. So that and the orientation of them means that if they contract, then they're going to elevate the ribs. There you go. Yeah. So the posterior is on the 1st and the 2nd rib. Let me just go back here. That's the longest curly again. We'll just skip past this bit. Here we go. Here's the scalenes. So right at the top of the neck, there's your anterior. There's your middle, and there's your posterior just there. So yeah, we've got the cervical attachments up here, and then as we come down, we've got the attachments onto the ribs. So anterior and middle first rib, so at the front and the middle. Posterior first and second rib. Okay, so the kind of merges across the two. There we go. Cool. So that's your scalenes. What time are we at? Yeah, we got good time. Okay, nearly there. So then we're going to have a look at the posterior part of the neck. And we've already had a look at the suboccipitals. And do you remember when I was saying, oh yeah, being able to palpate rectus capitis minor? Okay, so hopefully this will prove my point. So now we've got semispinalis, this one, and that is on top of your suboccipitals. Yeah, so this is covering them. So if you have, if you're doing any kind of movements of the neck, so extension specifically, or rotation, because this extends and rotates the head, you will activate your rectus capitis minor, major, and the obliques. But you will also activate this muscle here. So if you feel a palpable contraction, you can't tell where it's coming from. Yeah, because this one's contracting at the same time. You can't just switch off one and then contract the deeper muscles underneath. So yeah, again, it's not to say that the treatment is ineffective or whatever. The outcomes are still the same. It's just that when you're saying, oh yeah, I'm working on this muscle, it's not entirely true. It's the whole region that you're affecting. So origin C4 to C7, that's the bit we're interested in the neck, but obviously we can see it's coming from a lot lower than that. And the insertions on the nuchal line of the occiput. So if you remember on the other ones, it was the inferior nuchal line. So it was underneath the nuchal line. This one's actually on it. So again, just give you an idea of how close they are together, where they attach on the skull. So we've got extension and rotation. Then we've got this one, splenius. This origin, nuchal ligament C7 down to T3. Okay, so the nuchal ligament will be around about here, and then it attaches onto the mastoid process, which is just behind your ear, and then the occiput, which is the base of your skull, which we've been looking at. Okay, and again, extension and rotation of the head, and it's on top of your obliques. Yeah, the oblique muscle, the suboccipitals. So yeah, again we've got, and that's quite a big muscle as well. So if the action is to extend and rotate, you will activate this muscle too. Then we've got this one on top of that. So we've got the trapezius now. This is on the occipital bone. The spines of C7, all the thoracic vertebra from T1 down to T12. So huge muscle. We're just going to be interested in this bit in the neck, just up here. So the upper fibers will elevate the shoulder girdle and extend the head. Okay, obviously working bilaterally. So this is my point with these layers. Yeah, so we've got suboccipitals. Then you've got splenius capitis, then you've got the splenius muscle, then you've got the trapezius, all stacked on top of each other. So again, accurate palpation is impossible. Okay, here we go. Let's have a look. You make your mind up, see what you think. So these are the neck extensors. They obviously help with rotation as well. So that was the scalenes. That's where we just were. There's your clavicle. Coming round the back now. There's the base of your skull. Spine of the scapula. Superior angle of the scapula. Here we go. Semispinalis. Yeah. Really big, broad muscle. Look at all that tissue that's there. It just kind of like splays out and then attaches onto the base of the skull. So all the way up here. So it's got quite a broad attachment on that nuchal line, and the suboccipitals are underneath there. Look at that one. This one's meaty. So splenius. Okay, that one is then on top of your semispinalis. Yeah, semispinalis and suboccipitals are underneath there. Yeah, there's loads of muscles right around that suboccipital region, and this one attaches just a little bit higher. So they kind of arrange themselves in graduated attachment points. This one here looks like the Rectus Capitis from the attachment site. We'll talk about that one when we get to the shoulder. And then here's your trapezius, and that's on top of that. Yeah, so semispinalis, splenius, and then your trapezius, all on top of each other, and then the trapezius attaching up into the occiput as well. Okay, so the bit we're interested in is around about here. So you've got the nuchal ligament, so the trapezius will attach into that, and then down onto the spine of the scapula, onto the acromion, which we'll cover when we get to the shoulder. Okay. But yeah, the point that I wanted to make with this video is there's your suboccipitals, and then they just disappear. So you've got semispinalis, then your splenius, and then your trapezius on top of that. Just watch this through and through again. So yeah, the semispinalis will go down into the thoracic spine region as well. Quite a broad attachment on the occiput. And then here we go, yep, splenius on top. And you can see the nuchal line there actually, just there. Yeah, so your semispinalis and your suboccipitals are underneath that attachment point. It's just kind of just slightly below it. Mastoid process around the side there. And then the last one, well, there's your levator cap, so that's a little bit to the side. That attaches C1 to C4, but transverse processes, so it doesn't go up to the occiput. And then there's your trapezius just there on top. Yeah, so if you're treating someone's neck, if you do body work, then it's that whole region that you're affecting. Yeah, and just because you can palpate certain things, it doesn't mean you're affecting certain muscles and isolating them. And I think that's the key. As soon as we can get our head around the fact that it's not an isolation thing, it's quite a global treatment, then the better, really, because we try and blame muscles for things, and that they can't be blamed. It's like with piriformis syndrome. You can't. We don't call it piriformis syndrome anymore because there's so many other muscles around there that could be contributing to some kind of sciatic nerve entrapment that it's impossible to isolate it. So it's now called a deep gluteal syndrome. Okay, so and the wording does matter, because I think people then get really worried about the piriformis and getting treatment on the piriformis and all that kind of stuff, and you can't isolate it, similar to why you can't isolate this. Ligamentum flavum. Is this common in lower back pain? Sorry, Steph, I've just seen that come through. It's less likely in the lumbar spine. It's more in the neck. Sometimes you can get lumbar spine ligamentum flavum hypertrophy in the lumbars, but it would, from what I've seen, it's more in the cervicals and thoracics with car accidents, that kind of thing, because of the lordotic curve in the lumbars and then the protection around the lumbars. You'd have to be really flexing the lumbars to stress that ligamentum flavum. Okay, I don't. Yeah, God, you'd have to be bent double, I think, to be able to influence that. Yeah, clients always fall asleep when you treat the neck. Yeah, definitely. It feels good. It feels nice. Last one, sternocleidomastoid. I just love the name of this one. So it's from the sternum and the clavicle onto the mastoid process. Okay, so yeah, when you first start reading these words, you're like, oh my God, it sounds like a dinosaur. What the heck does that mean? But yeah, sternum, clavicle, mastoid. Easy as that. Okay, so let's have a look at this one. last one of the day. So sternocleidomastoid. And here we are. This is a massive muscle as well. So there's your mastoid process just there. And here it is coming around here. So it's the one you can see when you turn your neck and then you side flex. You can see that one pop out. So it runs inferiorly. There it is there, look. And we've got two heads. Yeah, so we've got a sternal head and a clavicular head. So that's your sternoclavicular or sternocleido part of it. So there's the sternal notch at the centre. Let's just have a look at that again. So mastoid at the top here, so that's just behind your ear. Quite a broad muscle. Split into two at the bottom, but merging into one at the top. And as it comes down, and when they pull it up, you can see the two heads. There we go. So you've got the sternal head and the clavicular head. And there it is there. Okay. Yeah, really, really superficial. Yeah. The sternocleidomastoid is literally just under the skin. Okay, so in terms of being able to directly palpate something, yes, you can. Because if you turn your head side bend, you can literally grab that muscle because it's so superficial. Suboccipitals, forget it. Yeah, you got no chance. Perfect. So that is the muscles of the cervical spine. Just get rid of that. We have got one more session left this year. So we've got next Monday, and then I'm going to have a break for 2 weeks. So from the 23rd, and then I'll be back in the new year. Okay, so next week we'll have a look at the nerves, probably the blood supply as well in the neck, and depending on how much time we've got, and that should finish off the neck then, and then we'll be starting. We'll go down into the shoulder in the new year. Okay, cool. Thank you, Martin. Thank you very much. Glad you enjoyed it. And yeah, I will see you guys next Monday, 10 o'clock. See you then.